work with the Africa One Health as the country manager for the AFROHUN country chapter based in Makerere University, the College of Veterinary Medicine, Animal Resources and Biosecurity. Briefly, I'll take you through the housekeeping rules, and then we will have our opening remarks from Dr. Mark Yambayamba from AFROHUN DRC and from Dr. Jabel from the University of California, Davis. Thank you so much. So kindly, please rename yourself with your proper name and organization. If bandwidth allows, please keep your videos on. Keep mics muted at all times unless speaking. We have French translation or interpretation services. Try by clicking the available button, or you click on interpretation and choose the language that you would like to hear. To hear the interpreted language, only click mute original audio. For live transcription, click on live transcription and choose a show, subtitle, and caption would appear on the screen. To close the caption, click hide a subtitle. For questions and chats, use the chat feature for any questions or comments and reach out to the IT team for any technical difficulties. Chat echo IT to track. For recordings, this session is being recorded and your attendance is consent to be recorded. Recordings as well as the presentation slides will be shared by email after the session. At obtaining a certificate of attendance, you'll be asked to complete a 2 to 3 minute survey. The link to the survey will be provided in the Zoom chat near the end of the session. AFROHUN will also correct registration, participation, questions and answers, chat comments, and poll responses. Your individual data will be kept really confidential. This data will be used for reports, maps, communication, survey, quality assurance, evaluation, or research, and to inform new initiatives. Thank you so much. The agenda will have our case presenter after the opening remarks. At this very point in time, I'm going to welcome Dr. Mark Yambayamba from AFROHUN DRC to give us an opening remark. And thereafter, we'll have Dr. Jabel to do the same on behalf of the consortium. You're welcome, Dr. Mark.
Yeah, thank you very much, Angela, for giving the floor. Hello, everyone. Bonjour à tous et bienvenue. It's my honor and a pleasure to be welcoming you to this first AFROHUN Community of Practice session. We will be discussing about Ebola. Indeed, this is the first session, and we hope to have more sessions where people coming from our AFROHUN member countries can learn and share, and that will help us to grow and share information according to emerging infectious diseases that we are having in our countries, helping all of us to be prepared and to get more knowledge as a multidisciplinary workforce. So for those who have just joined us for the first time, AFROHUN is a network of universities and higher education institutions across 9 countries in Africa. So we are part of a great network in Africa that is promoting the One Health approach. And we are very much happy to have you with us today. I thank our colleagues from the Global Consortium who have been able to support us during this activity. Here I'm talking about the ECHO team, Jaber and Mary from the Global team also, and then the Regional Secretariat, Christine and all of our colleagues at the Secretariat. And yeah, thank you very much, Angela, for coordinating this effort for this first session. We are very much happy for finally having it. And thank you for all of our guest presenters who have been able to give us their time to share their knowledge with us. So thank you so much. We hope you will enjoy this session. You will learn and share what you know in the chat. And yeah, very much happy to have all of you and wishing you a fruitful session. Thank you.
Thank you so much for those wonderful remarks, Dr. Mark Yambayamba. I take the honor to invite Jabel from the University of California, Davis, on behalf of the One Health Workforce Next Gen Global Consortium to give us some remarks, and then we will follow the agenda. You're welcome.
Hello, can you hear me? Angela?
Yes.
Okay. Hello, welcome everyone. And thank you, Mark, for these beautiful words. Mark mentioned that this is the first ECHO session, but he forgot to mention that this is the first ECHO session of the year. So far, over the last 4 years of the One Health Workforce Next Generation project, which is a USAID-funded project, we've been running several ECHO projects, particularly during COVID-19. And so now that the COVID outbreak went down a bit, we kept the good habits of having this community of practice and tackling other health challenges, such as Ebola right now. We all are experts in our fields, but with the One Health approach, we are working together to make this place a better place for us and for our children. And so we'll welcome everybody to the sessions. Please use French and English. We'll have everybody speaking languages, and we have translators. And we are more here to speak and share rather than listen and sit down. And we'll hopefully have you more in future sessions. Thank you, everyone. Thank you for the team who organized everything. They have been working on this for months and months. And we hope that you will enjoy it as much as I will do. Over.
Thank you so much, Jabel, for those wonderful remarks, colleagues and participants. I take this opportunity to invite Mr. Justin Okello. He's going to be
Angela, have we lost you?
Yes, I take this opportunity to invite Mr. Sorry about that, Justin Okello. Justin Okello will share a case on the Ebola virus disease. He holds a bachelor's degree in biomedical laboratory technology from Makerere University and a master of veterinary preventive medicine from the same. He has a wide experience in One Health. He has participated and investigated a number of outbreaks. Justin will present to us what the problem is, and together with the audience, we'll see clarity, and we'll then hear from the subject matter experts on how best we can address the emerging issues within the case presentation. The case presentation is based on the Ebola virus disease, and it's under the theme of the emerging and re-emerging diseases that will be happening as we'll communicate at the end of the ECHO session today. Justin, are you there? Justin?
Yes, Angela, and everybody on call, good evening from Uganda. I am Hon.
Kindly feel free to open the presentation and share on your end. You walk us through the case for 10 minutes, and then we'll have 5 minutes for any clarifying questions. Then we will have the SME come in. You're welcome, Justin. The floor is yours.
Thank you. Yes, I hope you can see my screen well. Good. Once more, good evening. I'm Justin Okello, as Angela has already hinted on. I'm basically a research associate at College of Veterinary Medicine, Animal Resources and Biosecurity of Makerere University. Have a degree in laboratory sciences, but recently I just completed my master's in veterinary preventive medicine with hopes of joining a PhD soon. This evening, I'm going to share Ebola virus disease outbreak in Uganda with a case study on the outbreak response. To start with, Ebola virus disease, of course, earlier known as Ebola hemorrhagic fever, is very rare, but often very severe and fatal in human population. The wildlife has been on spotlight with issues of these spillovers and outbreaks of Ebola virus disease into the human populations, but also intra-human transmissions have been very widely documented. Ebola virus disease has a case fatality rate of about 50%, but in the last 6 outbreaks that occurred in Uganda, case fatalities has ranged from 25 to 90%. A typical case of EVD presents with the symptoms and signs of fever, fatigue, pain, headache, sore throat, and among others. Of course, to also zeal in further, Uganda is one of the countries agriculturally based in the eastern part of Africa. It is, of course, landlocked with approximated population as of 2022, about 44 million, and the population 9 kilometers per kilometer rather. Ebola virus disease, like I earlier hinted on, Uganda has experienced about 6 cases of EVD outbreaks, with the most fatal one being experienced in the year of 2002 in the northern districts of Gulu and the Bundibujo, as well as in 2007, and the latest 2022 in Mubende district. Of course, again, to zeal on further, to throw more light, in the first case of EVD outbreak was in the year 2000, that is in Gulu district of northern Uganda. This was characterized by high mortality rate and also high levels of hemorrhagic manifestations. Affected where the health workers and as well as general population was worst hit. Of course, recently, Mbende, the EVD outbreak that lasted 114 days, of course, was responsible for the death of about, rather cases that were registered were about 140, responsible for about 30 deaths, therefore. EVD has got devastating impacts and implications, including but not limited to loss of gross domestic outputs, threat to food security, fall in employment and as well as livelihoods, decline in foreign investments, among others. The recent EVD outbreak in a given district in Uganda could be traced back to September 2022, where a patient believed to have traveled to a neighboring country presented with the typical signs and symptoms, including chest pain, joint pain, low appetite, diarrhea, nausea, vomiting, among others. Quickly, with the help of 2 family members, he was rushed to a traditional healer within the same setting where they lived. Of course, the traditional healer later on referred them, the patient and as well as the supporting team, to the nearby healthcare center. A sample was taken off from this patient and referred to a facility where testing was further conducted. Of course, at the facility, it was also documented that the healthcare worker operated or supported this patient with no appropriate personal protective gadgets, And unfortunately, within 3 hours, the patient breathed his last. Of course, the samples that were earlier sent to a laboratory found that the patient X had turned positive for EVD. The results were then sent back to the facility, and the district health officer, as well as the resident district commissioner, were all notified of this development. Furthermore, the resident district health, the resident district commissioner, as well as the health officer, collectively sent a communication to the Ministry of Health. And at the Ministry of Health, a team composing the minister herself, a press conference and declared an of EVD in Uganda. This was followed suit closely with the constitution of a response team. At this point, the question is, how should an outbreak be communicated and or declared? And by the way, who should be involved in the press release and the associated processes? Also, to respond to the EVD outbreak, the team that was earlier constituted by the Minister of Health arrived, of course, in the District X, and they were led by District Health Officer, who gave them an update on the development that had transpired. Within the affected households, the community rejected them largely, pointing and actually stigmatizing that these family and or their associates the ones that would be spreading this infectious disease. The district also requested for support to conduct research to ascertain the exact clear cause of the EVD outbreak. The response team that was composed was not comprehensive enough to address all the requests that were made by the district's residents, as well as the affected village. The team was further reconstituted while in the field, and another special force was sent comprising of different stakeholders, this time including academia, to see how better the problem of the outbreak associated to EVD could be better addressed. Of course, the government of Uganda and other international partners, including World Health Organizations, as well as UNICEF, immediately put in place preventive measures. These included regular hand washing of soap and water, keeping, of course, all sanitary places clean, including toilets, the toilet handles, and also regularly washing clothes and utensils and other necessities. Of course, the government also instituted community education and as well as risk communication mechanisms. Furthermore, the government tried its level best and set up isolation facilities for self-barrier, for quarantine, for lockdown, and as well for lockdown. Again, we are wondering what could be the possible barriers towards the implementations of specific interventions following an outbreak investigation. And clearly, at what point of an outbreak investigation will it be defined as being complete and accurate? Stakeholders on call and all protocols observed, I thank you so very much for the wonderful audience. I submit to you, Chair.
Excellent presentation, Mr. Justin. Thank you so much for presenting the case to us. Audience, do we have anyone with a clarifying question? Was the case clear to you? Is there anything you need clarity on? We have 5 minutes for this. Rogers Wambi, Mr. Rogers Wambi.
Oh, thank you.
And
thank you, Angela. And Justin, thank you for that wonderful presentation. Mine was maybe where I didn't get right. Let's go back at the start. Because earlier, Ebola was called the what? The viral hemorrhagic fever. It was among the viral hemorrhagic fever. But now, right now, I see it being called the Ebola virus disease. So I don't know what could be the changes there. Thank you.
Thank you so much, Rogers, for that question. Justin, do you want to respond? Do you want to make that clear to Rogers and the audience? We also have a hand from Mr. Philippe Ngere. Kindly go on.
Yeah, thank you so much for the concise presentation. Just seeking some clarity. Yeah, we informed that the patient first of all sought care at a herbalist place, and the herbalist even finally again referred this patient to the health facility. Out of curiosity, I'm just wondering, why would a patient like that go to the herbalist first? Is it a common practice, or did the patient maybe thought the condition could not be managed at the health facility? And secondly, the herbalist again refers this patient to the health facility, which is a good practice. I don't know, did the herbalist carry out any procedure? Did the herbalist handle the patient before referral? What is the story about the PPs behind this? And do routinely herbalists refer patients, any other ordinary patients, to the health facilities, or they've been sensitized and they have high index of suspicion, and therefore anybody presenting with certain syndromes are immediately referred to the nearby health facility? Thank you, and over.
Thank you so much for those very wonderful comments. I'm going to take one last one from and then we'll get a response from the audience, or the SMA can come in to raise. Welcome. Philippe, kindly hand. Mr. Guma Williams, please go on, your hand is up. Mr. Guma Williams, are you there? Maybe as...
Good evening. My question is about the index case. The last 6 Ebola outbreaks in Uganda involve no identification of the source of infection for the index case. Now, my question is, how can we build the capacity to account for future sources of infection for index cases of that nature? Because it is the one which can help us to really prevent further outbreaks. Thank you very much.
Thank you, William. Anyone from the audience would love to give a response on why Ebola is no longer really termed as hemorrhagic, but termed as Ebola virus disease? Daniel? Yes, please.
Yes, thank you, of course, all members from the audience for those very technical, critical observations. To start with, Ebola virus disease, now the name is just because those are the infections within a group of viruses from the genus, of course, Ebola virus. And that distinguishes it from other hemorrhagic fevers. Also, tracing the index case should also mention very clearly that different communities have got different practices. So already by the time of September 2022, there were community deaths already happening in the stated district X. And unfortunately, by the of the identification of this outbreak, a number of people had already passed on. So identifying the index case and also tailoring it with what happened with the traditional healer, that was just due to very high index suspicion or high EVD suspicion. Henceforth, the patient was further taken to the nearby healthcare clinic. Yes, I submit, Angela.
Angela, are you there? Okay.
Yes, Christine, I am.
Go ahead, Angela.
Thank you so much, Justin, for that wonderful response. I'm going to request the assembly to come and wrap up all the questions, and later on, he will give us a didactic presentation on in line with what the case presenter has already shared with us. Our subject matter expert in this case is Mr. Daniel Urian, who holds a bachelor's degree in environmental health, a master's in public health from Makerere University. He completed a training in advanced field epidemiology. Mr. Daniel has investigated over 30 outbreaks of various causes. He currently works as the Global Health Security Agenda Coordinator and Baylor College of Medicine. And he has been at the center of a response.
Okay, Angela, can I go ahead?
Please.
Thank you. Let me just try turning on my camera if my bandwidth will accept. I don't know whether it's clear now. Can you be able to hear me?
Yeah. Yes, we can hear you, Urian.
Okay, thank you. So I just wanted to go ahead and reiterate some of the issues, the emerging issues that came out of the presentation from the case presenter. And again, Mr. Kello, thank you so much for the great presentation. So I wanted to re-emphasize things that that needed to be emphasized earlier on. One is that the consequences that our case presenter presented about Ebola, of course, the economic, about the devastating toll. What did not come out very clearly for our audience is the impact on trade. If you may recall, all of us are in this fight trying to implement the International Health Regulations Framework. That's the IHR, which is really a binding WHO agreement among partner countries that every country commits to prevent infectious diseases with the potential to cross borders without necessarily disrupting trade. And we saw this actually play out during COVID. We saw disruptions because of lockdowns. And for Uganda particularly, during the Ebola outbreak, Uganda has a lot of tourists coming into the country. And actually tourism as of last financial year, I think it was ranking #2 as the source of foreign exchange. During Ebola virus, the number of tourism went down by over 80%, and you can only imagine the economic toll. So it's very important for our audience to know that diseases of this magnitude go just beyond causing death and disease in the public, but it has more ramifications in terms of trade. The other thing is the questions that were posed by the case presenter regarding the response team, whether it's adequate or not. So usually when an outbreak or suspected outbreak of a hemorrhagic fever is detected, usually the Ministry of Health quickly does an assessment. For example, this one was a confirmed case. So the team that was sent to the field to do initial response was based on the initial assessment, probably thinking that it's one case. It's also important to look at the background that the most immediate outbreak before this one was in 2018, where we registered 4 cases of Ebola, and these were imported cases from Congo. And because of early detection, Uganda did not register a single secondary case from that last Ebola outbreak, because all the cases were identified early and all of them were isolated and some of them repatriated. So I just wanted to make that point that some of the constitutional, the teams constituted to go to the field is based on the initial assessment. When the team reached the field, we realized that we were actually late by about 2 months. The moment you are late by more than 2 weeks for an Ebola outbreak, you know that there are many people intubating, and therefore the amount of resources that you need in terms of human resources is enormous. And that's why there was reorganization to have more teams deployed ahead. Yes, thank you, Angela. So the other thing was, at what point does an outbreak end? Yes, so an outbreak is declared over once we count 42 days after the last case. So we expect that those are 2 incubation periods. For William's case and Rogers' case of herbalists, I think I will address this in my didactic because we are losing a lot of time. So if you just allow me, I'll go ahead and share my slides here. And please be sure to type in the chat if you think that I'm so fast, I can be able to reduce. I will not go ahead to introduce myself. Angela has already done justice there. So my name is Daniel Orien. Currently, I work at the Ministry of Health. I work with Bella Uganda, but currently working with Ministry of Health as an emergency and response coordinator at the national level. I'm an epidemiologist by training. So the didactic I'm going to take you through is really the journey of Ebola in Uganda for the last immediate outbreak that you have had. But before I delve into that, I just wanted to take us through for our audience that's probably interfacing with this for the first time. We know that Ebola is of very much interest to us because it's a zoonotic disease. And because it's a zoonotic disease, we know that these are diseases that can jump from the animal side into the human side. And because of that, it is very important for us to know exactly how that happens. So Ebola virus, before it comes to the human population, has different stages. We have this enzootic cycle, and basically this is Ebola circulating among bats, where new evidence has suggested that most likely the reservoirs. How exactly this transmission happens in the bat population is subject to additional research. But Ebola has 5 species. That is Zaire, Sudan, Typhus virus, Bundibujo virus, and Reston. And we know that Ebola virus, Sudan, and Bundibujo mostly have been the ones causing havoc among human populations. It's also very important to note that this virus jumps to humans once we interact with these animals that are infected with Ebola. Once the first person usually does that, it jumps to the human population through either the fluids, through eating the meat. And again, this goes to Mr. Guma's question. Why is it that we do not usually get the first index case? if we do not have a robust surveillance system to make sure that we detect this early. Usually it is very difficult. By the time you go, you'll find that it's like 3 generations of transmission. And to drill down to the first, you'll find that most of them actually have died. And the people who have died will not give you their first account. It's also not true that we do not know all the index cases of Ebola viruses in Uganda. Like I said, the most immediate outbreak before this one was 2018. And that one was as a result of importation. So we know the first person who came to Uganda, and just to let you know that we did not get any secondary transmission to any Ugandan because of the early identification then. So the emphasis is really the early detection. So what do we take away from this slide is that increasing interaction between humans and animals is going to cause more of these outbreaks. We are very certain that this is not going to be the last outbreak in Uganda, and certainly not in some of the other countries that have experienced these outbreaks before. This is just a map to show you the history of Ebola in Africa. You can see, you can now begin to place where your country is located, and you see the level of risk that you have. You can see Uganda there having multiple outbreaks, and you can see how close Uganda is to DRC. DRC has that big Congo basin that we all know that has a very rich biodiversity that has resulted into various Ebola outbreaks. It's also important to note that the first Ebola outbreak in humans was detected in Congo, and that's why it was named after the river where it was detected. That is the Ebola River, if you have time to read through the history. So you can see the Ebola in West Africa, and you can clearly see the belt that these countries continue having the risk of Ebola because of the geographical location. Just to show you a little bit of insight again, and which might again apply to a number of us. So the map on the left clearly shows you that Uganda borders Congo. And traditionally, we, as a country, we have, because of the risk in Congo, we put a lot of resources in preventing importation of Ebola from Congo when it happens. However, this time around, we got Ebola, which was, the risk was within. You can see the map on your right shows you the history of Ebola in Uganda, and it shows you even the different species, the Sudan Ebola virus in red, Zaire Ebola virus in green, and then Bundibujo Ebola virus in yellow. You can see the shaded one is the recent outbreak that spanned over all those districts. So it has led us to look inward, that whereas we are looking at Ebola coming from Congo, we actually have an internal threat. And this is going to be give us radical changes in our surveillance systems as Uganda, as we go into the after action review for the recent outbreak. And again, the question that I will pose to all of us here is that, looking at the risk that I have presented there, based on that risk map, do you think your country is at risk of Ebola or not? And again, do you think that the risk that Ebola presents to your country is internal or external? Mind you, take into consideration the fact that there's increasing populations across all our countries. But again, these increasing populations are making us to cut down forests. They are making us get closer and closer to this animal biodiversity. So our interactions are increasing. So whereas you are looking at the outbreaks outside, it may not be surprising. So I want you to ponder through these questions. You can actually send through some of your answers to the chat, and we'll discuss them. Yes, so there's a question, there's a poll that has already been set. You can go ahead and answer that. So again, I just want to pause a little and take you through the journey of the Ebola virus outbreak in Uganda. So this is an epic up that clearly shows you the importance of early detection. You can see that the initial part of this outbreak, the color pink there shows you probable cases, and those probable cases are actually death. So the case definition for the Ebola virus in Uganda for a probable case was that it is a person who has signs and symptoms of Ebola, but died, and we did not get a chance to confirm using a laboratory diagnosis. So a number of people had died in the community in the affected districts for a period of close to 1.5 months. 1.5 months, if you computed divided by 21 days, you're talking about close to 3 generations of transmission in the community. So you can see the outbreak was detected on 20th of September. And you can see all those days that we lost. And we started investigation here. So you can already see that people who were deployed to the field first were actually seeing the tip of the iceberg, because a number of people were incubating the virus in the community. Again, what this EPICAP shows is that given the recent past outbreaks of Ebola, Uganda was able to control this outbreak in under 114 days from the date of declaration, even when we detected late. This speaks to a lot of the efficiencies that went into the response, but does not take away the initial lack of early detection. But again, some of the interventions that went here were actually new to Ebola. Before, we were not instituting lockdowns. So you can see again here, we show that we were able to apply lockdowns within a limited geographical location in 2 districts to curtail movement. And the reason for this lockdown, many may ask, is because we had lost time. Some people had died, some of the contacts we didn't know. This was just to buy time for us to be able to identify contacts from the community. Again, so after a detection of the outbreak and declaration of the outbreak, before response, Uganda usually does the initial risk assessment to respond. As you're aware, Africa is a resource-limited setting, but as COVID showed us, that even in the most resource countries in the developed world that we know of, in the event of a very big outbreak, those resources can be overstretched. So usually during an outbreak, we do risk categorization in Uganda so that we prioritize resources in areas that help us to control the outbreak as early as possible. So you can see the map on the left shows you the initial risk categorization that was based on 6 districts. The first districts of being very high risk and the rest of the districts being moderately at high risk. And this was because of the proximity to the districts that were affected. Later on, as the outbreak moved to the other districts, you can see the map on the right clearly shows you that the outbreak spread to other districts along major highways. You can see the bold line there shows you major highways. So based on this evidence, the National Task Force recategorized the districts and into 2 categories. Those that had at least 1 case and the rest of the country, because now at that point we knew that because of the high connectivity, Ebola would move to other districts if we did not pick those contacts. So the second question I will pose, and after this question, I think I will pause and we look through the chat and some of the emerging questions before we can proceed. So the next question I pose here is that what would have been done to detect the epidemic early? And this is a general question that can apply to your country. What are those tools that you deploy in those circumstances to be able to detect Ebola early? And do you think that the regional lockdowns are effective in controlling Ebola outbreaks? You know the experience from COVID-19. So at this point, before we move on to the next, I think it's the right time to just look through the chat, and I'll pause for a moment and just give colleagues time to be able to ask the questions. Angela?
Yes, these are going to be posted soon. Can you support with that?
I think the second question has been posted.
Daniel, kindly proceed as we respond to this.
So we're still waiting for questions. Do I proceed? Okay, so as we're waiting for questions, I'll just go through the presentation. We'll appreciate those questions as they come in. So overall, I'll just take you through the numbers for the overall the outbreak that just passed. So overall, we had 9 districts that were affected during this outbreak, of which 55 people died. And these were the confirmed deaths. Out of the 142 are confirmed, out of the 142 confirmed cases. So if you do the math, you realize that the case fatality rate here was 39%. And again, the case presenter.
Yes.
Sorry, Angela, you're saying something? Yes, so the case presenter had given case fatality rates of previous outbreaks that are ranging from 20 to 90%. Surprisingly, this case fatality rate was not as high as the previous. And again, I will speak to some of the things that may have led to this. But again, I think this is also subject to evidence that has been collected. These different species of Ebola may have varying case fatality rates. In this particular case, we had the Sudan virus, but we know that the Zaire virus is really deadly and can have case fatality rates that can range up to 90%. Interesting to note is that currently we have a cohort of 87 survivors that survived the Ebola, were confirmed, but went through isolation and discharged as negative. I'll talk through that soon. Just briefly looking at some of the characteristics that came out of the cases that we had during this outbreak. In terms of the person characteristics, we had almost all age groups really were affected of Ebola. But interestingly, for this particular outbreak, we had case fatality rate very high among children 0 to 9 years, of up to 74% overall case fatality rate. And if you have to look at the confirmed alone, that was 57%. And particularly the age group 40 to 59 also had, interestingly, very high case fatality rate of up to 78% if you look at the case-specific fatality rate. So again, this is very important during response. You need to monitor who exactly is affected, how are they affected, because usually infectious diseases, definitely like any other disease, affect our populations differently. So this informs interventions. What is very important to note about this outbreak is that, as you can see from the pyramid on your right, that both sexes were almost equally affected. But interestingly, that the highest number of persons who are affected here were the population between the ages of 20 to 40 years. They're the ones that actually drove this epidemic. Angela, please feel free to stop me in case you have got adequate questions that we can respond to. So in terms of the time characteristics, I have already talked about this. I talked about the lagging time that we took in order to detect, characterized by the earlier deaths of the probable cases early on, and then this culminated into very high transmission later. I'll talk a little bit about this. So if you are to drill down into this epidemic curve, you realize that early on in the epidemic, it was mostly persons between the ages of 20 to 29 and those 40 to 49 who were affected. However, later on, However, later on, as I said, this epidemic that you can see was majorly driven by the age group 20 to 29 and 30 to 39, as you can see by the pink and the blue in the second peak there. But interestingly, if you have to look at this disaggregated by females, and again, this would be very interesting depending on the jurisdictions, early on, almost all our cases were actually female, as you can see from the epi curve on the right. And this gradually moved into the males. Now, interestingly, during this epidemic, because you know the roles that females do, most of them are the ones that take care of the sick. They're the ones who take them to the hospital at home. They're the ones that take care of them, shower them, or do all the nursing. However, we saw a number of males, especially 20 to 29, who become affected. And this was mainly because these males were the ones who participated in transportation of the sick. because once they're sick in the community, these are the boys who ride the motorcycle taxis. And here in Uganda, we call them the border borders. We found many of them actually got affected because either they carried a sick person to the hospital or they carried a dead body. And you know that in a remote setting, sometimes these dead bodies are carried even without proper wrappings and all that. And we saw that driving the epidemic later on. You can see in the second peak, almost over 70% were actually male. So in terms of the regional distribution, I already talked about the epicenter. This outbreak started in Mubende. And again, going back to William's question, the difficulty in getting the index case, just like if you have watched documentaries of the West African outbreak. If you have an outbreak happen and it takes you time to detect, most times you're going to have all the first people die. And in this case, you can see the long time we took to detect this outbreak and a number of people dying in the community. And then once you are doing your investigation, you are only going to rely on people who are alive. The people who died long time ago, and most times they might have not given out this information. So this happened in Mubende. Very quickly, you can see how it moved to the neighboring district of Kasanda and Chegegwa. Then later on, because of the travel of these contacts, some of the cases ended up in Kampala, which is the city setting, and some went as far as Jinja, the district. So you can again see the peculiarity of the transmission here following those patterns. Okay, so I'll present this slide, then I'll respond to the questions. So again, I will present this in my last slide, but I thought I needed to highlight this early on. During an outbreak of Ebola, Ebola is a propagated disease that is transmitted through propagation. As you can see from the epidemic curve here, it is a typical propagated outbreak where you see the subsequent peaks are most times higher than the previous. So the mainstay of intervention here is really contact tracing. And the main reason you're contact tracing is that you want to find out all the cases that are exposed and bring them into isolation so that you avoid further transmission. So during this outbreak, we managed to track how best we are doing with contact tracing. You can see that at the beginning. Yes, go ahead, Angela. Angela,
thank you so much. There's no interruption. There's some questions and responses that we made to the previous polls that we had. There is a question from Mr. Sia Agri. He says that it's just a question about the 20 probable deaths. Was active case search done around the health facilities to document the signs and symptoms of these 20 people plus other community members? I'm thinking about whether our registers, e.g. the outpatient and the inpatient, together with the lab registers, and also other healthcare work, and what other healthcare workers do, whether they do this regularly. That's one of the questions. And the other one is really coming from Mr. Boniface. His hand has been up for the last so many minutes. Kindly unmute and present your question. Then the SME will have an answer to read. Thank you. Boniface?
Thank you, Chair. I hope you can hear me.
We can hear you.
Thank you. My name is Boniface Waweru from the Ministry of Health, Kenya. We are very much appreciative of this platform. We are sharing ideas. It's very interesting. I also want to say thank you to the two presenters. It is, a very detailed presentation that helps us understand how the outbreak in Uganda evolved. So the first question applies to the last case that was confirmed in this outbreak, the 142nd case. There were reports that that case was a preterm baby, and you may correct me if I'm wrong. What do you know about the transmission? How did the baby end up getting infected with EVD? That is number one. Number two, of these 20 probable deaths, and from the retrospective review that you did, which revealed that the outbreak might have begun much earlier, how does that information change what we already know about this outbreak? Were majority of these cases still coming from Mubende, or what information, or how does that piece of information
let's make the question very short.
Yes, how does that information compare to what we already know about the EPICOP? Thank you.
Angela, do I go ahead and answer them? Yes, so I'll go ahead and answer the questions. Do you have more questions?
I think Daniel, this is Sam. I think you can go ahead and answer.
In the chat room, it
Okay,
says, do you think there was any way to increase the contact tracing follow-up during the height of the outbreak? It seemed that about 30% or more EVD patient contacts were not able to be followed. Let's have an answer to those, and then we can proceed with the presentation. Thank you.
Okay, thank you about the questions. I'm really enlightened about the questions. It shows that the audience is engaged. The first one was about the probable cases, whether active case search was done. So these probable cases, you can only be able to identify probable cases if you do active case search. And then from the case presentation in those records that you review, that's when you are able to know that this person that died in this location was a contact of this person and had these presentations. And therefore, because of this presentation, and he died before we got the sample, this most likely was an EVD case. So this was based on complete case investigation, and actually all these 22, actually it's 22, not 20, probable deaths are linked to confirmed cases. And that is how we are very sure that these were actually probable. The second question is, there was a question asking, do you think tighter border policy can help with the surveillance? Just like I said, for this particular outbreak, we cannot pinpoint the finger. Our last outbreak as Uganda was importation from the DRC, but this particular one, there was actually no active outbreak in the DRC. So we think that it's an internal outbreak, and therefore the issues of tighter control happen when you have an active outbreak. One of the first things that happened in Uganda once this outbreak was announced was an interministerial committee that was attended by ministers of all the region here in Kampala. And that meeting was facilitated by WHO. That meeting was again to hone out strategies of how all the neighboring countries should be able to follow up and sharing regular information. Through these platforms is actually how Uganda was able to detect the last outbreak, sharing information with DRC. And that's exactly what Uganda did this time around, making sure that all our neighbors are aware about movement of our cases, movement of contacts, and preventing this from going out. And we're actually happy that this did not happen. We were not able to export this to any country. And that is really the spirit of the international health regulations, that we are able to contain these very dangerous pathogens at source and avoid disruption of international trade. So the issues of tighter policies, it's about enhancing surveillance and again, sharing information. The last case of the outbreak, yes, you're right. I'll just take you back to the EPICOP. When you look at the EPICOP, it kind of doesn't make sense. It looks like we had another outbreak, but this was actually a macerated stillbirth from one of the survivors. So during, one of the survivors was pregnant and she was discharged back to the community. She had already tested positive. But you know that EVD is a disease that can be transmitted from mother to child. So this child died, unfortunately, and that was tested and was got positive. And that's how it ended up in our final tally as one of our last cases. Then the last question was asking about the probable death. How does that change how the outbreak surveillance, how surveillance is done? So all these probable deaths were actually in Mubende. And it's what even points us to the fact that most likely the source of this outbreak is Mubende. But the teams are actually ecological teams and all other epidemiological teams are going ahead to do more studies to make sure that we find out where exactly the outbreaks came from. But we are very sure about where these cases came from. So I will proceed with the presentation. I will take more questions as they come. So the other question was about contact tracing. So yes, I was explaining that at one point when we had these contacts moved to other districts, some of these contacts slipped through and ended up in Kampala because they were seeking better health care. And in our system, we were not able to follow them up. And again, I was trying to emphasize that this is a very dangerous thing if you have Ebola and you're not able to account for all your contacts. This is exactly how we're able to get cases in Kampala that we're not initially aware about, and yet we had listed them as contacts. So efforts were made to make sure that all contacts listed are followed up to 100%. That's why you see later on in the epidemic, the follow-up went back to 100%. So the other question that I will pose again, just to relate to your jurisdictions, that based on the demographic characteristics that you have seen that I've presented, it's majorly, it started with the females, it then went on to the males, but again, it's majorly the age group 30 to 40 who was driving the epidemic. How best do you think contact tracing can be conducted to ensure 100% follow-up? Because you know, all these demographic classes have very different behaviors, and you should be able to know these behaviors in your country to be able to do that. So I'll pose that question. We'll see what the colleagues have to say. So I was just presenting that overview about our numbers in Uganda. Now I'll present how did we exactly go about with the management of the outbreak. Now, Uganda here, once an outbreak is detected, and again, I'll refer back to the test presenter, how should an outbreak be declared and who should be the one declaring this outbreak? So in Uganda here, it's actually a matter of policy. Once there's an outbreak, it is the Director General of Health Services of the Ministry of Health who is charged with the duty of announcing the outbreak. This Director General of Health Services is actually the chairperson of the National Task Force. This National Task Force brings together a number of stakeholders, includes partners, NGOs, government departments, and MDAs, and the Ministry of Health, and they discuss public health emergencies. So once this happens, and looking at the previous outbreaks, this has usually happened, the Director General of Health Services sitting together with the minister and the representative from World Health Organization and all other partners sitting on the round table and announcing as a team. This is very important for the public to believe the message that you're communicating, but also to make sure that one message is coming out. Usually during these outbreaks, it is a mix-up of information, breeds misinformation, and you can lose the outbreak response there. So in Uganda, the National Task Force sits and brings together all those stakeholders, but we also have the incident management system. The incident management system is the one that goes with the daily operations of managing an outbreak. And this incident management system is instituted and is commanded by what we call an incident commander. And it has a number of pillars. So again, this may vary depending on the outbreak, but also depending on the political structure of different jurisdictions. But here in Uganda, this incident management system, depending on the outbreak. For this particular Ebola outbreak, we had 11 pillars, including case management, surveillance, risk communication, logistics, coordination, water sanitation, laboratory, strategic information, continuity of the essential health services, research, and ecological studies. The continuity of essential services is a new one because of COVID, you know, because of the disruptions, you don't want to disrupt other medical emergencies. The other thing that you might have seen on national television, most times you have seen our president, His Excellency, give addresses, especially once he's giving out directives on lockdown or lifting the lockdown, because At the national task force, the president chairs and the ministry feeds the president with information and they take the decision at that level. As you are aware, management of outbreaks is managed by politics because you are aware politics is basically the management of society. Politicians are the ones that allocate resources. They are the ones that are in charge of the welfare of the public. So that's why you see at center stage, the president of Uganda is involved right from COVID-19 to Ebola. So this picture speaks to what I've already talked about, communication of an outbreak. So this picture shows you very high level leadership in the field in Mubende where the outbreak was. In the green dress there, you see the Honorable Minister of Health of Uganda. In the WHO jacket there, you see that is the WHO representative to Uganda. We have other partners. You have very high leadership from Minister of Health, the Permanent Secretary. So these are the teams that communicate strategy, communicate to the public to ensure that it is one message that goes out. But more importantly, this coordination pillar is the one that oversees the overall preparedness and response. It provides mobilization of resources. As you are aware that resources are needed most during an outbreak, and you need enormous amounts of resources. This can only be mobilized by the top leadership. So this is their core mandate and provide oversight to all other response pillars. One of the most important pillars that we've talked about also here is surveillance. Now, because of the uniqueness of Ebola, surveillance is divided into multiple different pillars to ease management. Surveillance is charged with helping to provide timely information that helps with decision-making. How big is the outbreak? Where is it spreading? Who is most affected? This information, you only get it through surveillance. And here in Uganda, from the COVID experience and into the Ebola, we usually have this divided into hospital-based surveillance, the point of entry, alert management, contact tracing that I've already talked about, the active search where you go to health facilities, you want to look through the records to find out who meets the case definition, you go to the community, so that you assure that with all these systems, you are able to pick up all the people who are sick in the community and be able to isolate them. Because the only way you can be able to cut transmission is by isolating the people that you think are exposed, have the symptoms, and avoid exposure to others. In this particular outbreak, we also actually had quarantine that I've not included here. As you're aware, quarantine is a person that has not even shown symptoms, but for some reason, your information shows you that this is a very high risk person. So you want to keep them in a particular location and monitor them over a period of time. This was very popular during COVID, but this was also effectively done during Ebola here in Uganda. And actually some of the cases we detected in Kampala were cases that we thought were exposed and did not show symptoms. And because they were quarantined, they developed symptoms while they were in quarantine and were able to pick them early. So these are lessons that were learned during COVID and they have worked during Ebola as well. The other intervention is case management. Ultimately, why we are responding is because we want to save lives. The first thing is you want to treat. We knew that the level of therapeutics were not yet advanced, but you want to provide supportive treatment. And therefore, you want to improve the chances of survival. Under case management, we also have infection prevention and control. As you are aware, one of the drivers of the Ebola outbreak, which was the biggest in 2000 in Uganda, was because of the nosocomial transmission in the hospital, where health workers get the infection, transmit to patients and to fellow health workers. So you want your infection prevention and control to be at the top notch. Safe and dignified burials. You must have seen in the media about, it was in the global media about how the community went ahead to exhume the body that was buried and ended up infecting over 20 people in that community alone who participated in the exhumation. So you want to make sure that everyone who dies with Ebola-related symptoms, you want to be taking charge of that burial regimen so that you avoid exposure. Again, Ebola, like COVID, comes with a lot of mental issues. So you want to make sure that your mental and psychosocial support is top-notch. but also providing nutrition. You are going to take a lot of people to quarantine. You're going to take a lot of people to isolation. You have to put them in a very good nutrition regime that helps them to recover, but also to survive, most importantly. I will not emphasize the very importance of logistics that is charged with providing the overall logistics for treatment, communication, distribution, all that. Yes, Angela?
Excuse me, Daniel.
Yes, go ahead.
Excuse me, Daniel. Kindly slow down a little. Slow
Okay.
down so that the interpreter can move with you. Thank you.
Okay. Yes, so just talking about logistics, you must be familiar with supply chains during COVID-19 because the whole world was affected. A number of challenges came in where stockouts would happen, but because everybody was struggling for them, so it posed challenges. So during an Ebola response, you can see the tent on the right there that was provided by the World Food Program. This World Food Program usually has the capacity to provide very big warehousing capability where you can keep all the inventory for an outbreak. So this is very important coordination of this. So this is charged with procurement of supply, management of these supplies, fleet management. As you are aware, the number of fleet you need to transport people from the field, transporting commodities and all this is enormous. The warehousing I've talked about, distribution, communication during an outbreak, establishment of operation site and security, all these fall under logistics. And you can see this forms the bulk of the budget of response. The other very, very important pillar that also goes a long way in helping control the epidemic is risk communication and community engagement. You have to give people the rightful information. You have to engage the stakeholders. If you do not win the stakeholders, then it means that, that you have already lost that outbreak. You want to build the capacity of the community, health structures, mass media. I think all countries saw the power of social media during COVID-19 transmission of fake information. So you want to be at the top of your game to make sure that all the fake information that comes, you counter it with facts about what's happening, then getting the information. The engagement bit of it is making sure that the local community is engaged from the start, because they are the ones who know who was exposed, they are the ones who know who died first. So you have to be able to use the different platforms. Here we engage them through our district structures, the village task forces that were formed during COVID, and having those intersectoral committee meetings where people share information. So again, one of the pillars that was born out of surveillance is what we call the SIRI pillar, the Strategic Information and Research and Innovation. As you may recall, during COVID-19, sorry for keeping on referring COVID-19 because it's what affected everyone, and it's the most recent experience that we can relate to. So during COVID-19, we watched on TV how advanced countries like South Korea deployed technology for contact tracing, where you could stand near a person and the phone of the next person rings and shows you that it's a high-risk contact. During COVID, we had a lot of innovators coming with all those sorts of information and deploying them. So we found it as a response team that it's very important to regulate this particular area, where not everyone is allowed to deploy any form of tool. Otherwise, people can deploy tools and use it to stream information that can sway the outbreak. So in this pillar, it has helped us develop a lot of capabilities. One is to improve data and digital tools governance so that everything that is used in an outbreak is something that is approved by the Ministry of Health and all the other partners so that everyone gets information there. To ensure that capacity for data analysis and visualization is done well. As you know, that use of data is the one that will direct the outbreak. You need to know who is affected, when, where. All those questions can only be answered with very good data analysis. And you have to develop this because data is what directs all the response. The other one is implementing integrated systems. Again, I've talked about making sure that these systems are not parallel. This may be different in other countries, but in Uganda, we are trying to develop this as one of the areas that is very strong. As you can see from the graphics that come from this response, these were actually snapshots that were taken from the presentations that we are making during the response. Make sure that all the decisions that are being made are evidence-based decisions. And then I'm about to conclude.
Daniel,
yes,
sorry,
go ahead.
You need to wrap up. You need to wrap up.
Yes,
Daniel.
This is actually the second last slide that I present. I already talked about a continuity of essential health services. As you are aware that this is the area that was born out of COVID because of lockdowns. You might actually lock people and you increase maternal death because of other medical emergencies. So because of that, every response now to that magnitude, we have a pillar that is in charge of making sure that whereas we are going ahead with responding to Ebola or whatever disease, other conditions like malaria attended to, other conditions like maternal health are attended to. And actually during the implementation, the response to Ebola, we also had actually a very big malaria outbreak. And to make sure you don't disrupt that, you have a dedicated pillar that enables this pillar to work well and ensure that this is done well. The other last one that I will talk about is really the investigations. Everyone wants to know where did this outbreak come from. This comes from science, and science and its time. So we have a whole of this pillar that is marrying from the anthropological studies, the ecological studies, and now we have actually even involved genomic sequencing to make sure that if indeed we think that we have found the source, is it linked genetically to probably the reservoir that we are looking at. So those are the studies that are currently going on. So my very last question that I will pose, do these response pillars apply to your country? This you can ponder on your free time. What important pillar do you think is missing that should have supported we as Uganda to be able to respond to this outbreak very, very well? I will just in a minute just summarize in a nutshell what is very important for every country. This is from WHO guidance. So to stop an outbreak, the key is identify and trace people with Ebola, safe and dignified barriers, and effective sanitation, hygiene, and infection if you have to break the chains of transmission. Treating people, you have to make sure that you care for the persons with Ebola and make sure that infection prevention and control is very good in the treatment units, and also medical care for the respondents, because this is very important to prevent fatigue. Ensuring essential services go on, I've already talked about this. Making sure that you preserve stability, reliable supplies and materials, transport and fuel, and then preventing outbreaks in countries that are not affected. This is why platforms like this are very important, making sure that you share transparent information with your neighbors so that if a contact has moved, the other country should be able to pick and avoid the outbreak at the site. And more importantly, research. That is the end of my presentation. I thank you for listening, and I will take the questions.
Thank you. Thank you so much, Daniel, for this wonderful presentation. We sincerely appreciate. Colleagues, allow me to thank our SME, a great presentation. We are going to have a link to the feedback survey posted in the chat in English and French. Please feel free to click on the link and respond to those few questions. And then we'll be able to get a certificate at the end of it all. The next session is going to be coordinated by Mr. Samuel Wanjohi. It's going to be a Q&A, very brief, 5 minutes. And then we'll have a wrap up of the session. Samuel, you're welcome.
Thank you. Thank you, Angela. Allow me to just start off by appreciating our presenter, Daniel, and also appreciating Justin for the case presentation. So allow me to just start off by asking Daniel to ponder over the responses that are given on the polls. What would you, in 1 minute, Daniel, what would be your feeling on the responses that were given on the polls that you asked? Daniel, are you still there?
Yes, thank you so much, Samuel. Yes, so I think it's just appreciation to the audience. They appreciate the strategies Uganda took, but I see the feeling is that the audience is trying to reflect on how exactly this applies to their own settings. And it's very important that we continue reflecting on this, because every outbreak is different. That's just what I need to emphasize. This outbreak is totally going to be different from the next Ebola outbreak Uganda will experience, but the principles stay the same. That's what I just needed to emphasize. Yes, sir.
Wonderful. So thank you, Daniel. You have several questions in the chat. I will want to give you some 2 to 3 minutes for you to give us concise answers. So I think I have 1, 2, 3, 4, 5, 6. There are 6 questions, so I'll give you 3, and then you answer them, and then 3. So the first one was by Asqual Gebreselassie. I think somebody's mic is on. Admin, kindly mute Feli. Feli, may you mute, please? All right, great, thanks. So you had a question from Asqual Gebreselassie, and he was asking, can we control Ebola for the future in Uganda? Anyways yet? So that is question number 1. Then Fiston Muneza asked, thank you for the presentation. Regarding the fatality rate, 50%, I think this was from Justin's and your presentation. Regarding the fatality rate, 50%, who are the most affected? And he puts in brackets risk factors for EVD death. Who are the most affected? These are the risk factors for EVD death. And then for this first batch, Kebede Mbaye Gezai asked, why is EVD still an important public health concern, particularly in some African countries? Why is EVD still an important public health concern, particularly in some African countries? And how effective do you think the One Health approach is in addressing EVD? Daniel, in 1 minute, if you can respond to those 3, then I'll give you the last 3 questions.
Great question, Sam. The first question, how do we control future outbreaks to Ebola? It's just improve capacities for detection, early detection. We are not going to say we are going to stop this completely. We live in this area where we have the virus. There will be crossover from the animals to humans. That one we can be sure. But how then do we put systems in place to detect early? And that's already ongoing. The case fatality rate of over 50%. So for me to authoritatively talk about the risk factors, I know several people are studying this, and you will find this in published literature very, very soon. However, from the descriptive data that I've presented, you could see that overall, the children less than 9 had a high case fatality rate of up to 70%. Even persons 50 to 59 had that very high case fatality rate. Why exactly this happened? Again, this should be something that studies that are ongoing should be able to answer. Why is it important public health emergency in Africa? I would like to respond to Kevedi that this is going to be actually increasingly a bigger public health concern to us because of the increased interaction between us and the animal. We are cutting forests at a higher rate than before, and people are opening up land. We still have practices of people eating these animals. So it's a very important One Health. So the only way we can do this is to improve the One Health approach, ensure that the people in the animal sector environment work with the health so that we're able to detect this early and reduce the interaction. The other thing that is driving us to do this is climate change, as you're aware. Our agricultural communities are moving closer to these animals because of the livelihood. So again, the One Health approach will be the one solution. Sam, hope I've kept within the time. Back to you, Sam.
Wonderful, wonderful. Thank you, Daniel. The next set of questions. Sia Agri asked, just a question about the 20 probable deaths. Was active case search done around health facilities to document the signs and symptoms of these 20 people, plus other community members? And he says, he or she says, I'm thinking about whether our registers, for example, outpatient or inpatient and lab registers, and also our healthcare workers do this regularly. So was active case search done around health facilities to document signs and symptoms, plus for the community? Then Diane Kensky asks, do you think there was any way to increase the contact tracing follow-up during the height of the outbreak? It seemed that about 30% or more of EVD patient contacts were not able to be followed. So do you think there was any way to increase the contact tracing follow-up during the height of the outbreak? And finally, Roger Zwambi asks, what is the best way to handle quarantine and isolation, be conducted without becoming an amplification center? So what would be the best way to handle quarantine and isolation without making them amplification centers? Daniel, in another 1 minute, precisely give us concise answers as we go on to near the wrap-up. Thank you.
Thank you. So again, a correction, the probable deaths were 22. And how were these documented? Yes, so this followed the active case search. And as you're aware, active case search does not only happen in health facilities. Yes, you go to health facilities, form registers, find who had signs and symptoms of Ebola and what was their final outcome. Active case search also went to families where people died and did not show up in the health facility, but had signs and symptoms of Ebola and were exposed. So yes, we have challenges to do with documentation of records in remote health facilities. But again, this is something that was picked up. And just to clarify that most of these deaths actually happened in private health facilities. And again, just to tie with the earlier question that why do you think people prefer going to traditional healers earlier asked? Again, people have different preferences depending on the cultural setting. And this particular cultural setting in the central part of Uganda, there are still a number of people who believe in the traditional herbalists. So as part of our surveillance, we actually included them as areas where we do active search. The other one, do you think there was a way to increase contact tracing? Yes, it's through community engagement. Again, it's only the community that is going to tell you that this person got exposed, he was the one caring. So initially, it's because there were some families that were resisting declaring. Because they had some of the deaths, it is through using some of the anthropologists, the psychologists to talk to them that they're able to open up and tell us more of the contacts. So again, this area of community engagement is very key to win the public to give you all the information. And then lastly, ways of handling quarantine. Quarantine and isolation, IPC. Make sure that IPC is top-notch. There's no cross-contamination between different segments and managing the different cohorts. For example, if someone came in today, you don't want to mix them with someone who is finishing quarantine on the 21st day. So basically, in summary, IPC is very key within quarantine centers and then isolation. Back to you, Sam.
Wonderful. Thank you, Daniel. I'll give you a virtual clap. Members, ladies and gentlemen, allow me to invite you to use the icons there and give Daniel a virtual clap for the responses and for the presentation. Daniel, we appreciate you. Justin, we also appreciate you for the presentation and sharing the expertise. Thank you. Thank you, members. I see the claps coming in. So with that and with the responses that Daniel has given us based on the clarifications that we've sought, colleagues, members, ladies and gentlemen, we are coming to the end of this session. This is session 1. We want to appreciate you for taking time to join us today. I want to draw our attention to the links that have been put in the chat. Kindly take the survey. To get your certificate for this particular session. So we request that you give us feedback. And in the event that you have other questions emanating from the presentations, kindly do not hesitate to reach out through the email that was sent you the invitation. Send us your questions. We will relay them to the subject matter experts and definitely get you the responses back. Our next session will be 1 month from now. The last Wednesday of February is when we'll be having our last session. We look forward to seeing you then. Allow me to again just politely remind you to take the survey so that then we can be able to know how to improve these sessions moving forward, and for you to also benefit by getting that instant certificate at the end of your taking of the survey. I wish to remind us as well that resources will be shared by email, and we'll be giving you notifications of when the next session will be coming up. Now, AFROHUN and the One Health Workforce Next Gen Consortium have the One Health Workforce Academies in place. If you would wish to get more additional training and additional information on investigation and response, we have a course actually on outbreak investigation and response. There is a link in the chat to the One Health Workforce Academies. Kindly, if interested, kindly click that link and register and take the course. Again, outbreak investigation and response, there is a course being run by the One Health Workforce Academies. This is through the One Health Workforce Next Gen Consortium, AFROHUN, as well as AFROHUN. So kindly click on that link and register to take the course and other courses as well that we'll get that are being administered through the One Health Workforce Academies. Lastly, in the announcements that I'd wish to share, I just want to appreciate my colleagues from other AFROHUN countries, Senegal, DRC. I know we have colleagues, of course, from Uganda. Angela has done a wonderful job taking us through this entire session, as well as other colleagues who may not have joined us. AFROHUN currently covers 10 countries across Africa, and I just want to appreciate each and every one of my colleagues, and also members of the Communities of Practice Technical Working Group under the AFROHUN network. I do not also want to forget to appreciate our team from the ECHO team, Yuta, Connie, and other team members, and Noah and other team members that have worked behind the scenes to make this session a reality. So to the ECHO team, we want to extend our appreciations to you for making this a reality. Participants, ladies and gentlemen, this would not have been possible if you had decided otherwise, if you had decided not to join this particular session. And so because you deemed it worthwhile, we hope that it has been a value addition to you, our participants. Now, our members or members of the communities of practice, we want to appreciate you for deeming this worthwhile, for making it a reality, for joining this particular session so that we can all learn from each other. So to you, allow me to give each and every one of us a virtual clap, and I believe we can all do that, a virtual clap to every one of us. I also want to appreciate our secretariat, the AFROHUN Secretariat, the One Health Workforce Next Gen Consortium for giving us the support, and USAID. USAID has made it possible for us to have this session, and so I want to appreciate them for making this a reality for us as well. It is 3 minutes past the top of the hour. I want to give an apology for these 3 minutes, but thank you for still staying with us and sticking with us till this very end. Again, we look forward to seeing you in the next session, the last Wednesday of the following month. I wish to remind us to take the survey. The links are in the chat if you haven't done so already, and also give you a direction to the One Health Workforce Academies course on outbreak investigation and response. Kindly click on the link and take the courses as you may be interested in. Thank you once again for taking time. If you have other questions, please do send them to us via email. We will share with our subject matter experts and give you their responses. Materials will be shared back with you via the email. With that, allow me then to just wish us all a good evening and a good morning and a good rest of the day from wherever we are joining us from. And we really look forward to developing these communities of practice, making it vibrant, having it as a forum for us to share knowledge and experience and expertise across the various countries that we are joining in from, so that then we are able to effectively safeguard our continent and benefit our communities and our societies. And so with that, on behalf of the team that has coordinated this particular session, I wish us all a good day and a good evening, and see you next time. And it is a bye-bye from me.